Hello, everyone. My name is Ed Hickey, and I'm the president of the American Association of Kidney Patients, as well as chair of AAKP's Veterans Health Initiative. As a fellow kidney patient, it's been my honor to serve the kidney community through the great work of AAKP for nearly a decade. It's my great pleasure today to welcome you to the 7th Annual Global Summit on Kidney Disease Innovations, an AAKP partnership with our allies at the George Washington University School of Medicine and Health Sciences. This event was launched in 2019 through the vision and hard work of our esteemed summit co-founders and co-chairs, Dr. Dominic Raj of GW and Paul Conway of AAKP, and has become the largest kidney patient-led innovations conference in the world, engaging tens of thousands of people across more than 100 countries. On behalf of our organizations, we are honored to host this important event that brings together patients, researchers, clinicians, policymakers, and industry leaders from around the world. This global summit has always been more than just a meeting. It's a movement. It's about sharing bold ideas and opportunities, showcasing groundbreaking science, identifying and overcoming barriers, and most importantly, putting patients at the center of innovation. From emerging therapies, scientific discoveries, to expanding patient care choice and access to all treatments, the conversations we have here are shaping the future of kidney care. As we mark the midpoint of the decade of the kidney, this year's summit provides a critical moment to reflect on the progress we've made since AAKP launched the Decade of the Kidney initiative in 2019 during our inaugural global summit. We'll discuss some of the remaining barriers to future progress and prepare ourselves for honorable work that lies ahead. Together, we can accelerate solutions that offer hope, improve lives, and reimagine what's possible for kidney patients everywhere, leading to greater freedom from disease and disability. But before we begin, I'd like to recognize this year's Global Summit sponsors for their generous support, including our silver sponsors, Amgen and Vertex Pharmaceuticals, our bronze sponsors, Hansa Biopharma, Mallinckrodt Pharmaceuticals, and Otsuka Pharmaceuticals, and our patron sponsor, Maze Therapeutics. It's now my distinct honor to welcome a good friend, trusted ally, and co-chair of the Global Summit, Dr. Dominic Raj. Dr. Raj serves as the Bert B. Brooks Chair of the Medical School, Professor of Medicine, and Director of the Division of Kidney Diseases and Hypertension at the George Washington University School of Medicine and Health Sciences. But beyond his many titles, Dr. Raj is a visionary scientist and is passionate about kidney care for kidney patients. His exceptional leadership has not only strengthened GW's standing as a globally and nationally respected institution, but has also deepened its connection with the kidney patient community in a very strategic and substantive way. Dr. Raj appreciated there were many important kidney-related scientific and medical conferences across the world, but few substantively welcomed the most important stakeholders, kidney patients, as a full and equal partner. His shared vision for the Global Summit was intentionally designed to transcend that status quo and, along with it, the future of kidney science and innovation. Today, the summit stands as a model of a true and pure partnership and collaboration among patients and healthcare professionals. We're united by our shared commitment to advancing innovation, improving lives, and ultimately preventing and curing kidney diseases. Thanks to Dr. Raj's leadership and dedication, I believe our joint endeavor has far exceeded expectations, and it is with deep appreciation and admiration that I now turn this program over to him. Dr. Raj?
Thank you, Mr. Hickey, for the kind introduction. It's always a pleasure to see you. Now, welcome to the 7th Global Kidney Summit. I cannot but look back with pride what we have accomplished since its inception in 2019 and the transformative changes in kidney science since then. The purpose of the Global Kidney Summit is to advocate for increase in patient engagement, increase investment in innovative discoveries, and shape equitable public policies across the globe with the goal of improving patient outcome. We certainly have made significant progress since. The concept of Global Kidney Summit began as an abstract wish by three dreamers, Mr. Paul Conway, Dr. Jagdishan, and I. We met in late spring 2018 to discuss the possibility of organizing a different kind of kidney meeting. Paul and Jag were very optimistic, but I was daunted by the enormity of the undertaking. We wanted the summit to be different and patient centric. We all agreed that this should serve as a platform which brings the patient perspective to the researchers, physicians, industry, and policymakers. The inaugural summit was held in April 2019. It was a tremendous success with the organizational wonders of Diana Kleins, the support of former AAKP President Mr. Richard Knight, and AAKP staff. The entire division of nephrology at GW, faculty, fellows, and staff contributed to fundraising, organizing speakers, chairing sessions, and delivering lectures. It was an amazing display of collaborative strength. The former chair of medicine, Dr. Wasserman, went beyond closing the clinics and permitting residents to attend. He personally attended most of the sessions. He was very proud. We had 5 international speakers, about 200 people attending in person, but more than 9,000 virtual attendees. The summit received a lot of attention and was applauded by all the kidney stakeholders. We called it success. The 2019 inaugural summit was launched as a hybrid event, in person at GW Jack Morton Auditorium, and was live telecasted to international audiences. This is Brian Hess, a kidney patient, a lifelong kidney advocate who authored the book Kidney Failure Won't Stop Me. He challenged us to do more in kidney innovation and improve patient care in his inspiring speech at the inaugural Global Kidney Summit. Leaders from NIH, FDA, and several representatives from industry spoke at the summit and welcomed the opportunity to interact with and learn. There was an enthusiastic and energetic participation from kidney patients with sharp comments and intelligent observations. But in 2020, we were forced to go virtual due to COVID. The rapid growth of the program and the popularity among the international audiences made it logical to transition to a permanent virtual program. The Global Kidney Summit has seen amazing growth over years, driven by the unique format and inspiring content. Since the inception in 2019, we have constantly strived to outperform ourselves each year. The number of viewers peaked at 25,000. The participating countries have progressively increased from 50 to 170 in 2024, with speakers sharing their views from 15 to 20 countries. Through the summit, we gave voice to both developed and developing countries. We highlighted the key advances in kidney science, celebrated key policy successes, boldly highlighted why research is needed, and existing policies impede progress. The summit took meaningful themes each year, mostly coined by my co-chair, Mr. Paul Conway. The inaugural call was to disrupt kidney disease progression. We sought the international voice, seeking the World Health Organization to recognize the epidemic of CKD in the second summit. Asked for more choices in the management of kidney patients in the third summit. Search for the key to accelerating innovations in kidney space in the fourth. Challenged ourselves asking, if not us, who in the fifth. And boldly announced that this is time to prevent and cure kidney disease in the sixth summit. In the present one, we are asking to knock down barriers to greater innovations in kidney care. Switching gears, in recent years, we are rediscovering that kidney disease is an important cause for cardiovascular disease and death. This reluctant discovery is well-known secret to nephrologists for decades. Richard Bright, a 19th century physician, widely known as the father of nephrology, made significant observations linking kidney disease to hypertension and heart disease. It came as a surprise to many that Framingham heart risk equation underpredicted cardiovascular events in individuals with CKD, but not for the nephrologist. In 2013, by the American College of Cardiology and American Heart Association introduced the pooled cohort equation to predict the 10-year risk of hard atherosclerotic vascular disease events. They did not include measures of kidney function in the equation. We tested the utility of pooled cohort risk equation in patients with CKD and found that it is not applicable to patients with CKD. We showed that addition of GFR or glomerular filtration rate and albuminuria improved the prediction of atherosclerotic events in CKD patients. In 2023, American Heart Association proposed the prevent risk equation that incorporates GFR and albuminuria. The Global Heart Kidney Care Alliance has been established recently. Supported by Bayer Global, this initiative strives to educate the stakeholders on the unmet need of patients with kidney disease and heart disease. This alliance is expected to break barriers in collaborative science and therapeutics with the ultimate goal of improving patient outcome. The United Nations aims to reduce premature mortality from non-communicable diseases by a third by 2030. For this initiative, WHO recognized cancer, heart disease, stroke, chronic lung disease, and diabetes as major non-communicable disease drivers of early mortality. However, they failed to include kidney disease in the initiative. Kidney disease stands as the third fastest growing cause of death worldwide. It is an important cause for premature mortality, disability, and reduced quality of life. Kidney disease also imposes heavy financial burden on healthcare system. Securing WHO recognition is important because it will raise the global awareness about the kidney disease, help develop guidelines, and standardize the care for CKD, enable presentation of surveillance program, and furthermore. Also, increased resources allocation can lead to new therapeutics. Industry saw what WHO did not recognize. Recent nephrology drug market analysis, which does not include dialysis economics, valued the nephrology drug market at $20 billion in 2025 and is expected to reach $30 billion by 2032. The primary driver for demand or surge in prevalence of CKD, recent advances in precision diagnostics, and incentivizing research in orphan kidney diseases. The primary driver for drug discovery include better understanding of molecular mechanisms of kidney disease, discovery of novel delivery systems, drug repurposing programs, and advances in biologics. Now, clinical trials are designed with primary renal endpoint, a great success for nephrology. 2024 has been a golden year of innovative kidney disease therapeutics. We now stand at the cusp of groundbreaking treatments for kidney disease driven by technological innovations and deepened understanding of pathophysiological mechanisms. We have tamed the immunity to perform xenotransplantation and exploring CAR T therapy for lupus. Gene editing technology from eGenesis enabled development of human compatible kidneys for transplantation. Understanding the molecular basis for kidney disease has unleashed several novel interventions such as RNA interference, for primary hyperoxaluria, guanylyl cyclase activator for treatment of proteinuria. ProKidney is a bold biotechnology that could potentially regenerate the fibrotic kidney. Incretin therapies have extended beyond diabetic kidney disease to non-diabetic CKD as well. Several novel therapies are launched with promise of slowing the progression of IgA nephropathy. The Kidney Precision Medicine Project created the comprehensive atlas of human kidney, which could accelerate discoveries. In the field of renal replacement by dialysis, the Kidney Project is poised to deliver bioartificial kidney and NeoKidney, a small portable dialysis technique. Artificial intelligence is being explored for personalized kidney care. This is certainly exciting time for nephrology and for the patients. Angela Davis said, I am no longer accepting the things I cannot change. I'm changing the things I cannot accept. I wish to thank you everybody for attending this year's Global Kidney Summit. Now, it's my pleasure to introduce Mr. Paul T. Conway, the co-chair of the Global Kidney Summit. He's a Renaissance man who needs no introduction. His illustrious career includes leadership positions in AAKP and in the US government. An abbreviated list is provided here that includes Chair of the Policy and Global Affairs for the AAKP, Chief of Staff for the US Department of Labor and Agency Chief for the US Department of Homeland Security. In one word, there will be no Global Kidney Summit without his innovative thinking and agile execution. Paul, take it away.
Thank you very much, Dr. Raj, for your strong support of the American Association of Kidney Patients and your ongoing friendship. Without Dr. Raj's absolute steadfast loyalty and support for this initiative and that of the George Washington School of Medicine and Health Sciences, everything that we've talked about and achieved would not be possible. So we deeply respect your time and your investment and trust of kidney patients in all things. Dr. Raj talked about some of the successes and the ongoing opportunities we have to advance new diagnostics, drugs, and devices, and to make them accessible for patients throughout the globe. I'd like to talk for a minute and give you a patient perspective on what AAKP sees as some of the remaining barriers that we must be vigilant to watch for and address quickly when we see them and identify them. Speaking truth to power is not something difficult for kidney patients to do, and it's certainly not something difficult for an organization like AAKP, with our depth of policy background at the global and national level and international level, to be able to bring the voices of patients to problems when we see them. So let's talk about these. One of the ongoing issues that we think is a barrier is what we call medical paternalism. That's when some people in the medical professions think patients are the ones that show up, they participate in exams, but having a voice in the actual process or helping drive innovation is not something that readily occurs. So sometimes what happens is medical professionals have a bias, and they don't see a patient as an equal partner either in their own care or in larger strategic issues. I'll give you an example of this. In terms of risk tolerance, sometimes a doctor or a medical professional might substitute their own judgment about what a patient who's in a life-threatening situation might choose to experiment with or to try. We think that's wrong. We think there has to be an honest conversation and not have a substitution of judgment from a medical professional without a direct engagement with patients. Another barrier that we're concerned about is the ongoing issue of government determinants of health, or GDOT. This is when governments knowingly or unwittingly make decisions that negatively impact kidney patients. I'll give you an example of this. One of the most tremendous innovations that's come forward for transplant patients is the ability to use molecular blood testing in lieu of an invasive needle biopsy to check and see how their kidney health is and to address early organ rejection. Here in the United States, we went through a 24-month battle that is ongoing in many ways, where a federal agency decided that although this had been covered for many years, they were going to restrict coverage. So practically, what did that mean? That meant that transplant patients who had just gone through some of the toughest medical circumstances with COVID were now being denied access to frequent testing, if their doctors needed that, to make certain their organs were doing well. That's a government determinant of health, basically assigning those patients to higher risk and not being responsive to their need to take care of their gift of life. Our organization, with our allies, raised our voice, and we will make certain that that is corrected. But you see these examples a lot. If government does it, or sometimes insurance companies will do it. And this raises another issue for us to be vigilant about. A barrier to access imposed by an insurance company on a promising therapy for patients that could forestall or delay kidney disease and the necessity for a transplant or dialysis is absolutely wrong. And so we work with patients both internationally and here in the United States to identify barriers created by insurance companies that are not thinking in terms of the patient outcome, certainly not, and they're not thinking about the impact on families. We must keep our eyes open for these things, identify them quickly, and raise our voice. There's another issue that we're very concerned about, and this is what we would call the perversion of shared decision-making. Shared decision-making as an ideal is an important thing. It means an honest conversation between doctors and patients about what the best path of care is. At the American Association of Kidney Patients, we define high-quality kidney care as treatment decisions and early detection decisions that best support and empower patients to pursue their aspirations, like full-time jobs, part-time jobs, education, home ownership, and a secure retirement. But sometimes, in a shared decision-making situation, a medical professional might have a bias. They might have a bias against home dialysis. They might have a bias against asking certain patients whether or not they want to sign up for a transplant waiting list. We think that's absolutely wrong. And so we've taken on this issue to make certain that shared decision-making is patient-centered. We're producing our own guide on shared decision-making to make certain that the patient concerns are prominent in the discussion and not forgotten, that there's no hand put on the scale to try to dissuade patients from a certain treatment that might best serve them and their families. I'll give you a fast example. A couple of years ago, our organization was exposed to a policy issue that was in its early stages that would force kidney patients in the United States to check off the box to certify that they had undergone shared decision-making before they could get access to therapies like dialysis and organ transplant. That's not currently a requirement. That would be a change of standards for American kidney care. We fought against it, and we will keep fighting against it. But across the globe, you have many different entities that are interested in saying shared decision-making, but in substance, you have to look at the details because the patient should determine what's best for themselves and their families, working with medical professionals they trust. That's true shared decision-making. You'll hear more about that in upcoming events that we have. But we must be vigilant. We've talked about barriers. Just a few years ago at our Global Summit, we had the distinct honor of hosting former Health and Human Services Secretary Alex Azar. Secretary Azar had a father who lived on dialysis, and he pursued a transplant, and Secretary Azar was able to help him get a transplant and work through that process. He gave us a very important lesson from politics and public policy, which is this: there are no permanent victories in policy. There are only permanent battles. And that's what I'd like all of you to think about in your respective countries and how we operate as patients together. We have fought hard and achieved many victories and had many opportunities presented to us, but we must stay engaged. We must work together across international boundaries. As patients, we see the problem of kidney disease, and we're united in saving more lives. We should also be united in battling barriers when they're presented, because many of the things that are available to us and will become available to us as patients, for example, xenotransplantations, will not just take a national voice of patients, but it will take an international cry from patients for access and availability. We can speak for ourselves when it comes to patient risk tolerance. We can speak for ourselves when it means shared decision making and how that's important to us based on our goals and our aspirations. And we have fought to stay at the table in public policy discussions and medical conversations, but we're not going backwards. We're not going to suddenly leave the table because of a whim or an impulse from an elected leader or an appointed leader or career professionals that work in government who just may not understand where we're coming from. It's our lives that matter, and it's our lived experiences and unique insights that help industry, researchers, scientists, and medical professionals bring about great changes and innovations and bring them to the market. But we're an equal player, and we should never forget that. So we can overcome these barriers. We've overcome many in the past 5 years, but they'll always be there. But it will depend on our creativity and energy to knock them down. It's part of the reason we have this global summit. So please, join the American Association of Kidney Patients and our international allies and participate, engage, raise your voice, and mobilize. We're making an impact and will continue to do so. Thanks again, Dr. Raj, and thank you for watching.